Perfect. Okay. Hello, everyone. Thank you all for coming to our Echo session today. My name is Johaji Castillo, and I'm in my last semester of my entry-level doctoral program, and I'm researching the effectiveness of this virtual program to increase your confidence and knowledge on various topics. Today, there will be a 30-minute presentation and a real case study for discussion. You will learn from one another and will have your knowledge re-examined through a local lens. Through shared support, guidance, and feedback, this will lead to a collective understanding of how to implement the best occupational therapy practices across diverse settings. This program is free and available due to your participation in this research study. Therefore, it is highly encouraged that you complete any survey links you receive before and after the session. You will not receive a certificate of attendance unless you complete the pre and post surveys sent to your email. If you are not receiving these surveys, please let me know and I will send my email in the chat now. If you have any questions, my email again is in the chat, and I would now like to introduce Dr. Paula Rabaey.
Thank you and welcome. I'm just going to pull up here is just a little introduction slide about me. I am located in Minnesota in the US. Believe it or not, we'd had a mild winter and we just got dumped with snow last night. So I have been a pediatric therapist for 32 plus years, and in academia this is my 17th year. I don't know if any of you have heard of Spoon Foundation, but I serve on their medical advisory board and as a feeding technical expert, which is really where I have gained lots and lots of experience working with kids with cerebral palsy around the world, and looking at their different feeding needs. I am the current chair of the research pillar for Feeding Matters, which started as an NGO to really help families advocate for pediatric feeding disorder and also to facilitate evidence-based practice around assessment and intervention for kids with pediatric feeding disorders. So I'm going to share with you what I know, my expertise, and what I have learned over the years from working with kids with cerebral palsy across or in the US and across 8 different countries. But first, I'd like to know, maybe just type in the chat, like your level of experience with feeding kids with CP. Like, yes, I've done it. No, I'm not experienced at all, or I have done it a little bit. Okay, I'm seeing a lot of no experience. Some people with BOBATH. I'm also have done an NDT therapist, have done baby NDT. Okay, great. Well, hopefully today is designed to give some beginning experience and particularly what to look for in terms of having a very whole picture global assessment and some basic evidence-based interventions. So the objectives are on the slide. So really, I'm going to just kind of describe what the common feeding problems in children with cerebral palsy look like. We're going to talk about the evidence for current best practices in feeding children. And hopefully you'll be able to apply the knowledge in a case study. And I hope I could talk about feeding all day, so hopefully I don't go over the 30 minutes. The first few slides here are just to give some background about feeding difficulties. As you can see from the percentage of numbers, it's pretty high in children with developmental delays and neurodevelopmental conditions, particularly with children with cerebral palsy, especially who are more moderate to severe classification. And I think it's interesting, the third bullet point, 30 to 90% of children with CP, it's I think it's because we haven't collected great data across the globe. Um, but the prevalence of feeding difficulties in children with CP increases in children who have moderate to severe CP, particularly higher spasticity. So those would be levels 4 and 5 on the gross motor functional classification system. There are a lot of consequences and impact of feeding behaviors or feeding difficulties in children with cerebral palsy, not just with the child, but um, as you've probably observed or heard in your practice, a lot of stress on families. And especially for kiddos with more moderate to severe CP, a huge consequence of feeding difficulties is aspiration and dysphagia, which is difficulty swallowing. Aspiration can be it can actually be deadly, even for some kids who are aspirating their own saliva. There's a lot of aversive feeding behaviors because the feeding experience probably hasn't gone so well for them from the beginning. And so there's learned behaviors. When it hurts to eat, I don't want to eat. And then that leads to a really big cycle of frustration for parents. It leads to malnutrition and micronutrient deficiency. And as you can see, there's a lot of caregiver stress and frustration, which is what I've observed and talked to many parents in different countries about. And for us as OTs, it really comes down to decreased mealtime participation, which is a huge area of occupation. And every culture has their own different mealtime rituals and routines. But what I've learned from a lot of families is that children with feeding difficulties and CP often are left out of the family mealtime experience. So as I talked about, there is a really big connection between nutrition and disability with our friends with cerebral palsy. And this can interact throughout the life cycle, and disability and feeding difficulties together usually affects our most vulnerable children. And kids with CP already have disability, but then adding malnutrition, micronutrient deficiency on top of it can actually cause more disability. So for these kids, we want to make sure that we're really paying attention, not just to the amount of food, but to the types of food and nutrients that we can coach families to give them. This comes from the American Occupational Therapy Association, just describing OT's role in feeding, eating, and swallowing. And I think it's helpful to be able to explain this to our other rehabilitation peers, that we can evaluate and treat feeding, eating, and swallowing difficulties across the lifespan. And feeding is one of those things. I think it's one of the most, it's the most difficult occupation because it requires complex motor, sensory, and cognitive abilities. And feeding, eating, and swallowing, there's a definition for each, which we'll go over, they're independent yet interdependent activities. And the other piece that makes feeding difficulties so complex is that they're really influenced by psychosocial, cultural, and environmental factors. And just a note, if anyone has any questions at any time, please interrupt me. So when we are looking in the treatment of, I'm calling it pediatric feeding problems, but particularly feeding difficulties with our children with CP, we want to be looking at these outcomes. Not only we want improved health of the child, but really looking for improved quality of life for the child and family, decreased stress and mental health problems in families. The earlier we can work with kids, reduces the risk of long-term feeding difficulties and reduces healthcare costs to the family and society. So that's kind of a big background. These are the models of pediatric feeding for assessment and intervention that I like to use. I don't know the one on the far right, the pediatric feeding disorder, is from Feeding Matters, and it shows that the diagnosis is not only medical, but there's a psychosocial, a nutrition, and a feeding skill domain. And we are a lot as OTs situated in the feeding skill domain, which kind of translates over to the other picture on the far left about, we identify oral dysfunction in infants and children, but all of these things around it are things that we need to be looking at that can be impacting that. Particularly impaired postural control, which I'll talk a little bit about assessing, the actual oral motor issues and then swallowing issues, but also paying attention to, is there different systems issues that we need to look at, and are there other sensory and state issues, like the ability to have good self-regulation. Particularly, I'm going to focus on some of the evidence around impaired postural control, because about 90% of children with neurodevelopmental disabilities like cerebral palsy have feeding and swallowing difficulties, also have abnormalities in tone, posture, movement, and they have a retention of primitive reflexes, which really interferes with their oral motor function and feeding. And so most important is looking at the postural stability of the trunk, head, and neck. And so we're going to talk a lot about that. Then we'll talk about some of the oral motor issues and how tone can influence that, and some kind of tips and techniques for working with kids and guiding families and coaching families. So 3 key definitions that when you're working with any kind of child with a feeding difficulty that are important to know is differentiating between feeding and eating. Feeding, we consider, is the setup, arranging, and being able to bring the food from the plate or cup to the mouth. So it's like everything that impacts the food right up till it gets to the mouth. So this, for some kids, this could even be sights and smells. Then eating is the ability to keep and manipulate food and liquid in the mouth, and then start to initiate a swallow. So that's a lot of what we are paying attention to for oral skill. And then swallowing, which is the kind of the really complex act of which the food, fluid, medication, or saliva is moved from the mouth through the pharynx, esophagus, and into the stomach. And a lot of times we can't tell what's going on totally with the child's swallow unless they have a video fluoroscopy swallow study. And we know that for our kids with cerebral palsy, safe swallowing is really important for our health and good growth and nutrition. So some of the things, it's important to really know what the signs of aspiration are, so that we can help to reduce the chances of that happening, or we can refer to other medical professionals. And aspiration can be a combination of things, oral control, so in that eating phase, but also, especially for kids with a lot of tone or not enough tone, it's an issue of timing. So swallowing's not coordinating, the airway's not closing, and we all know what it feels like when we take a sip of water and it goes down the wrong way and we cough and our eyes water. And it's also being able to clear the bolus from the mouth, so from the cheeks and not pocketing, and propelled to the back of the mouth. So there are signs of aspiration in all three phases of swallowing, which is the oral phase. So that's what's happening when the food's in the mouth. So, for example, if I'm not able to chew my food and I can't get it to the consistency needed to for a safe swallow, I'm probably going to have a lot of problems with the pharyngeal phase, which is getting it to the back of the oral cavity and initiating a swallow. And then there could also be problems with the esophageal phase as well. Some signs to look for with difficulty in swallowing in the oral phase is maybe a lack of alertness with feeding. So particularly kids with lower tone, if they're not for infants, we don't want to, especially for kids we think have a delay, we don't want to feed sleeping babies because that affects their oral phase and because they're not really alert. Kids who have a lot of spillage from their mouth, if parents report it's taking an extended time to feed them, so greater than 30 minutes, kids who pocket food, gag with different textures, they can't transit the bolus. So they might just be pocketing in their cheek and not being able to push it around and propel it back with their tongue. Signs that a child is at risk for aspiration in the pharyngeal phase is some of the classic ones, like you hear coughing during or after meals, that wet, gurgly voice quality, difficulty coordinating respiration with eating and drinking. And then I always pay attention to if you have a child with CP and they have frequent respiratory issues or frequent respiratory infections like pneumonia, I might suspect aspiration, particularly if I know they have a lot of the risk factors. Esophageal phase difficulty is harder to detect, but some of the things is if the child really is giving some indication of pain, like there's arching of the body because it's not going down well, frequent vomiting or spit up, if there's a preference for only liquids. And again, this can differ based on the age of the child. And it's important to know that some children who aspirate don't have any signs, so they might have a silent aspiration. So when I do an assessment and I'm asking some of these types of questions to families and caregivers, telling me about, how their child handles food. Is there coughing? Is there choking? Is there vomiting? Do they notice like kind of wet, teary eyes? That could be a sign that the child's also aspirating. And asking about the different food textures that their child can handle best. So what does our treatment evidence say? And this is what we're going to go into. I should take a step back too for assessment. One of the things that I think is really important is to observe the caregiver feeding the child, because I want to see the position that the child is being fed in, typically at home. Is there any positioning equipment that families have or are using? I've worked with a lot of families who don't have access to a lot of assistive technology, so they're continually holding the child, which gets harder and harder as the child gets bigger. So we want to look at posture and positioning because that's going to tell us a lot about how that child might be able to chew and swallow. For example, if I'm being held and my head is always in extension, that's a really, really hard position to swallow in and to chew in. So that'll be one area that we want to include in our intervention. And then the next is diet and texture modifications. And this falls in the nutrition and skill domains. Oftentimes, our children with CP are not eating textures of food that correspond with what a typically aged child would be eating. So, for example, and this is hard for families to kind of understand. So I do a lot of education around this, is that, your 7-year-old child with CP might still be eating textures that are more for like, a 6 to 9 month old, because of their oral skill development or their lack of oral skills. So for our kids, especially with the most severe CP, who have to be fed, and we know that they will probably need texture modification their whole life, we want to make sure that we are helping families modify the food to the right texture, and adding, including things in their diet that boost the calorie count and the nutritional factors of that food. Because these kids often they're burning more calories than they're taking in a lot. And oftentimes, in some places where I've worked, the children are they're given, they have a limited diet of like porridge and yogurt and just, maybe mashed banana, because that's what they can handle. But we can add a lot of different things. We can grind up and blend or pound a lot of different other kinds of food to boost the nutrition. Equipment and utensils, which falls in the skill domain. And then oral motor treatment, which doesn't have as much evidence, but I will show some techniques, especially for our kids with moderate to severe CP. Oftentimes, we're not going to make big changes in their oral skill, but we can make changes in posture positioning, texture modification, and pacing and responsive feeding, that it makes mealtime a much better experience and a higher quality of life. So we want to pay attention to pacing and what I call cue-based feeding, which is the interaction between the caregivers and, oops, sorry, that went back by itself, and the child. Okay. These slides just go over the phases of swallow again. So I'm gonna skip over these rather quickly, but particularly paying attention to phase 1, the oral phase, where we're gathering food or liquid in the mouth and it's being prepared, like we have to chew it to a certain consistency. And then the second part of the oral phase, which is moving it back for swallowing. So we want to pay attention to that phase, but then we also want to be able to watch. We can watch to see if a child is swallowing. We can listen for swallows. We can listen to see if there's a delayed swallow. We can feel to see if there's a delayed swallow, so we can get an idea of what's going on in the pharyngeal phase. So this slide, these little stick figures here, is from an assessment that I helped create with Spoon Foundation, that goes through looking at the positioning. So I always, for us as OTs, positioning and postural control is the starting point. And it starts with pelvic stability. So we want to have the pelvis stabilized, then look at the trunk, and then head control, because usually the head kind of fixes itself once we get the pelvis and trunk in line. I remember as a new grad therapist, my biggest mistake was trying to start with the head. And really, we need to be starting with the hips. And my favorite saying is that what happens at the hips is mediated at the lips. So if we don't have good pelvic stability, we're not going to have good tongue control and lip mobility. So I always want to make sure that however you have the child, whether it's in a seating position, a chair, or in the caregiver's lap, and I have some pictures coming up, that you can get that pelvis to, now 90, 90, 90 is kind of like sort of the golden rule, but I'm going to tell you there's a lot of kids who can't get to 90, depending on contractures. So even if they can't get to 90, I want to, make sure that I'm positioning them as upright as I can and that the pelvis is stable. So whether that means a stable lap belt, I can use, a seating system. I can show the family how to use their own body, or I can use things that I find in the house, like a scarf or a piece of fabric to help secure the hips. And this is so important, I think, and this is in the literature as one of the most evidence-based for preventing aspiration. And we have to give the child adequate support so they're not working so hard at trying to chew and eat and move food. So the idea is proximal to distal. Okay. And then we look at the trunk. And so you can see on this slide, you can use this as a quick evaluation. Circle in each row that best shows how the child is positioned while they're being fed. So this is an observation tool that you can use to watch a caregiver feeding their child. And this again just points to showing the key points that we want to make sure we're looking at, starting with the hips, trunk, shoulders, knees and feet supported as much as possible. The better we can the more we can give our children with CP postural stability, we're going to increase the safety of, and efficiency of their feeding because we're giving them more stability. Safety meaning that we're going to decrease the risk of coughing, choking, or aspiration. Efficiency, which is important for families during feeding, means that the child is able to take in the appropriate amount of calories in the right amount of time without burning too many calories. So this slide, again, just shows some of the principles that you want to be looking at, and then recommendations for what you can do to help that with the child. So starting with, we want hips secured. I should have put that at the top. Trunk supports if needed. Also giving some support, tray or table for upper body support so you can get those hands at midline. And then foot supports if you are able, because we want the child to only have to focus on eating, not trying to keep themselves upright or stabilize their head. Okay, I'm like, 30 minutes. I'm gonna skip past this, but we can come back to it with the case study. Okay, so here's just some pictures. These are actually from the book put out by Hesperian, Disabled Village Children, but this actually, I've used these techniques for parents who don't have access to equipment, but just being able and making sure that they can actually demonstrate and practice. So 3 key things: keeping their hips at 90 degrees. So you can see the hips are at 90, even though the child is slightly reclined. That's okay, because we are keeping the chin slightly tucked. And head above hips. We don't want to be feeding children flat on their backs. And this is another way that works if a caregiver needs to sit on the floor. I always emphasize to caregivers that they need to protect their body. So having them sit up against a solid wall so that they have as much support for their arms and body so that they also are not getting fatigued, especially as those children with CP get bigger. And for those who have such high tone, because it can be really hard to keep them in a good position. So they can use a cushion or pillows to also support their hips, the caregivers. And these are just different I've seen lots of different seating devices kind of all over the world. Okay. So this should show, if you look at the pictures, which one is a more correct position for feeding the child? The one, anybody? You can put it in the chat, unmute. Yes, the one on the right. Okay, I was given the 5-minute warning, so I'm going to go through. Next, I'm going to give some tips and tricks for oral motor feeding skill. This is second after I've gotten the child positioned correctly. So I want to be able to, in my assessment, so if I'm watching a caregiver feed and I can help the caregiver adjust the position, I now want to see what the tongue, lips, jaw, and cheeks are doing. Okay, so because this is a key area for us. And we want to see like range of motion, the ability to open the mouth, are the jaws stable. And this chart is a nice chart that is a quick like look at what typically what the tongue, lips, and jaw should be doing typically at 6 to 9 months, 9 to 12 months, or 12 months plus, so that you can get an idea of what that child is able to do, and then how you can modify the food texture. So for example, if I am a sitter or I'm not able to sit yet, my food texture is going to be puree. If I'm a crawler, it's about equivalent to having mashed food, but it's a little bit lumpy. And walkers have enough postural stability that they're able to eat soft, diced foods. And it's really important to know that feeding skills are learned over time. So advancing a diet, even though families want it to go fast, is most accessible when you have a child who's ready to be able to eat the food types that they're being offered. And we want to advance diet and food texture based on developmental readiness, which is like these last two slides, and not age or diagnosis. This is some terminology. So a lot of you have probably seen, for our kids with CP, they have a lot of tongue thrust. So frustrating for parents, the food's coming back out of the mouth, and they have a lot of instability at their jaw. What you also might see is a bite reflex and limited range of motion around the lips and cheeks. I'm going to skip through here because I'm going to go to feeding techniques. So here's some quick feeding techniques to try when a child, these are kind of the common problems here on the left. And when a child is losing a lot of food or liquid out of the mouth, or unable to close lips on this spoon, we can give them jaw and lip support. So there's some pictures on the next slide, but being able to give them support here so that, and then I am able to help them, I can use my tongue, close their lips. Tongue thrust is a hard one, and my favorite is called lateral spoon. So this is a small spoon, but you can do it with any spoon. So instead of presenting the spoon straight on, you're going to turn it to the side. And this is also going to help with bite reflex because it's going to give them a cue at the lip, and they're going to be able to start using their lips and not get triggered, not get a bite reflex triggered, and it's not going to go onto their tongue and initiate a tongue thrust. All right. And the same techniques can be done with a cup. So this is just demonstrating giving some jaw control. And here's that technique for giving stability at the mouth for spoon feeding. Okay, I'm Okay. All right. So we're up to the case study, but I want to go back and just show a couple videos. Let me go back one. Let me see. Oh, okay. Here is, and I hope you can see it if it's playing. She has very delayed lip closure. She's had not a lot of experience with drinking from a cup. So I'm giving her I'm coaching, giving her a lot of keeping her head, even though she is positioned mostly flat because she has a lot of contractures, we're keeping her chin tucked. And you can see that her liquid is also thickened because she could not handle thin liquids at all. Okay. And here's another kiddo. So you can see tongue thrust. And then had nice lip closure, and again with thickened liquids. And you could easily make a cutout cup out of just a plastic cup or a water bottle. Okay. And then the same, I'm going to show, this is the spoon technique. Oh, this one's upside down. That's a bite reflex. So for bite reflex, I would have turned that spoon around. But if they're biting hard, avoid pulling and give a little pressure up under the chin. Wait, and then pull it out slowly. Oh, bite reflex, yes. Right there. So you see the child clamped the teeth down. Now she pulled it out. That child loosened it. But some children with a lot of tone, the more you pull, the harder they're going to bite. I have another question. Is using a bit of pressure with a spoon? Yes, it can be. For some kids who don't have as prominent a tongue thrust, but I like to teach lip skills to start to learn to close on the spoon with a lateral spoon. But yes, a little pressure down and then pulling the spoon straight out instead of a lot of, because it's easier, we want to scrape the food off on their tongue, but then the child has this kind of lump of food in their mouth and they're not learning the skill to manipulate it.
Dr. Paula, unfortunately, yeah, here we go.
Yep, there we go.
Case study.
Yeah. Okay, so how do you want to do, so does the case study done in groups?
We typically have you just read it out loud, and then once you finish reading the case study, we'll go ahead and break out into the small groups.
Okay, perfect. So this is an example of a little boy. We're going to call him Lyle. He's 2. He has a diagnosis of quadriplegic cerebral palsy with moderate spasticity. At this stage, Lyle's mother is concerned as he only eats puree and soft foods, has some episodes of coughing and occasional choking with eating, which causes him to cry and stop eating. More difficulties with liquids and frequently coughs with milk or juice. His food is limited to yogurt, mashed banana porridge, and mashed sweet potato. Lyle is not able to sit on his own, but has some moderate head control when supported. And that's the typical position, or mom holds him in her lap as the typical position to feed him. She would like to get a special chair, but there's a long wait list. She is not able to work as she has to stay home and care for him, but she's trying to start some economic activity that she could do at home. And sometimes access to food can be difficult. So 3 key questions to talk about. One is, what key elements will you address in your feeding assessment? And that goes along with what factors are contributing to feeding difficulties for Lyle. And then come up with 3 strategies or guidance that you can provide Lyle's mom to help minimize his feeding, eating, and mealtime difficulties.
Hey, welcome back, everyone. I hope you all had really great conversations. I know my group did. And so we'll go ahead and I'll ask the facilitators what some responses were. So it's starting with Lindsay. What did your guys' group discuss for number one?
Yeah, so for the first question, some of the elements that were brought up that people would want to investigate were definitely positioning. I know we saw that picture there, but then just looking more at like how the mom is facilitating feeding and what the feeding environment looks like at home. And then also if she's been using any equipment or like the utensils that she's using, and then also Lyle's oral motor skills and the pacing of feeding, and then seeing if like they're already using any strategies and things like that. So there were a lot of things brought up that people were curious about.
Great, thank you. Kelsey, what about your group?
Yeah, so our group also brought up like observing that feeding process and the positioning portion as well, and looking at those potential adaptations you can make for the positioning. We also talked specifically about the liquid intake and seeing what like that choking and coughing sounds like, and potentially looking at if thickened liquids might be helpful and trialing those. We would also want to see what other textures they have like potentially tried besides just the purees. And then we also wanted to address in the feeding assessment the potential issue with access to food or financial supports.
Thank you. And then because of time, we'll move on to the second question. Antonius, what was your group's answer for the second one?
Well, maybe drinking two liquid food instead of solid ones, posture and positioning, and maybe some portion of food stays in the mouth like in smashed potatoes.
Thank you. And then Jenna, your group?
Yeah, so we talked about the oral motor skills and muscle weakness and spasticity and how that can affect the ability for Lyle to feed. We also discussed the coughing and aspiration aspect and how if he's coughing when he eats, that's a pretty scary experience. So that could then also cause him to have less motivation to try new textures and consistency in foods. And then also the economic difficulties as well as limited access to support sources, which kind of goes along with the seating setup for posture, as well as access to a variety of different foods.
Yeah, I just wanted to highlight that my group really discussed a lot about access as well as the economy. And one of our members brought up using like the two corners of a room as support in the meantime until they get that special chair, which I thought was a really great idea. Okay, for the third question, Paula, did your group have any great insight?
We talked. Oh, did you say Paula? Yes. Okay, sorry. I was hearing an echo, I think. We talked about adjusting mom's position because right now she was having to she sat on the floor. This was her typical position and she didn't have a chair yet, but giving her we said the same thing, having her go up against a solid surface on the wall using the corner, and then helping her sort of, I like to like even cross create sort of like, I call it a little bucket in between my legs, so that we can get his hips more. You can see his hips are not really at 90, but get his hips at 90 so that his trunk, and then you can kind of support with your mom can support with his legs so that that head can get up, trunk and head can come forward to help reduce some of that risk of aspiration, and maybe adjusting her position because mom was really loving and caring, and he's trying so desperately to look at her, but looking at her in this position just causes more head extension, right? So kind of trying to adjust the position so he can see her more and she can read his feeding cues.
Thank you. And then last insight, Tolawalsi, your group.
Okay, so sorry, I think I kind of missed out. Oh, well, the group talked about mainly using positioning techniques, I mean, to address some of the problems and keeping the child in a more upright posture and giving a lip support. And someone also mentioned that the food texture could be changed, like what they try solid food with a child that might also reduce the liquid lures and someone else suggested larger spoon techniques to help the child. Well, in question two, I couldn't take that. Someone also mentioned about sensory issues that might be related, that might be influencing the process of feeding for this child also. Um, so basically, that's the only different thing from what every other person has said. Thank you.
Thank you so much. Okay, great group discussion, everyone. And
Can I add one last thing about what we
absolutely.
did try with this? So
Yes.
what we actually tried, this was when I was doing some work in Uganda that really helped this child, is once we got him in a good position and kind of changed so mom could see, this mom had said she had never used a spoon with him because she wasn't successful. And so she really was giving him everything in a cup. So it had no experience really learning a spoon. So I showed her the lateral spoon technique where with yogurt, because it was a favorite food. So he liked it. And when we got it on his lip, he started closing his other lip and he figured out so quickly how to suck the yogurt off the spoon. And all of a sudden he was using two lips together and mom couldn't get yogurt in him fast enough. He was so excited and so happy. So the lateral spoon technique really, really helped just even showing mom in the short term that he was able to work on using his lips to clean the food off.
That's great news. And with that positive note, we'll go ahead and conclude our session for today. Thank you everyone for coming in today. And please remember to complete the post survey that will be sent out to all your emails very soon. If you do not receive that post survey,